Alrighty. Welcome everyone to our Refugee Health webinar series. We're just gonna wait another minute or two for more attendees to join us, and then I'll get started with some disclosure slides and introducing our speaker today. Thank you.
Oops, what did I do? Did I do that?
Oh, the screen changing there? No, that was me.
Okay.
You're okay. Yeah.
Sorry.
Oh, don't worry. Okay, so welcome everybody to our Refugee Health webinar series. Today we will be talking about social work considerations for new Americans. And I'm just going to share my screen to go over a few of our disclosure slides. Share over here. So perfect. Yes, social work considerations for new Americans. Our CME disclaimer: CME credit must be claimed within 30 days of participating in the event. And I'll be sending out the CME information after this with also a link to the recording for today and the slides as well. Our financial disclosures, we have none. So easy slide here, which is great. And then as well, our Refugee Health page is here, which has our recordings listed on it. The slideshows from all of our previous Refugee Health sessions, as well as future sessions. We have one more left, so please join us on November 10th and register for that. From here, I'm going to introduce our speaker today, who is Cathy Kelley, the Social Worker Care Coordinator for the Pediatric New American Program at UVMMC Pediatric Primary Care, who will be guiding us today in our presentation. And I just ask that if you have any questions to please put them in the chat, and then time permitting at the end, I will ask Cathy those questions. So without further ado, I'll stop sharing my screen, Cathy, and let you get underway.
Great, thanks so much.
No problem.
And we will share my screen.
Yeah.
And I had that before.
Yeah.
Okay. And I apologize for that. Birdie, what am I doing wrong?
That's fine.
Can you see
Do you
it?
have the PowerPoint up now?
I thought I did.
And then you hit share screen in the bottom there.
I am so sorry.
That's fine.
We had it up and going.
Yeah, and it looks so nice.
Okay.
There you
I think
go.
we have it.
That's perfect.
Thanks for bearing with us. And welcome to those of you who are joining us live and those who will be watching this in the future. So we are going to go through this fairly quickly because I'm someone who over prepares and I do have a lot of slides. So our agenda for today, I'm going to share my experiences working with new Americans. I'm going to talk a bit about our Pediatric New American program at UVM Medical Center, UVM Children's Hospital. I'm going to go over challenges faced by new arrivals and lessons that I've learned over the course of my career working with new Americans. So my journey, it's been such an honor and a privilege to work primarily with refugees, immigrants, and other new Americans in a variety of settings for over 20 years. Those include Howard Center, CHCB, Connecting Cultures, which is a mental health program through University of Vermont. And I believe you'll be hearing from Dr. Karen Fondacaro in the next segment in this series. And then at UVM Medical Center. So I have a few important disclaimers to put out there. I have many years of experience as a service provider working with new Americans, but no lived experience as a refugee. I'm the granddaughter of immigrants, and I put a little picture in there from Derry, Northern Ireland, which is where my grandparents came from. But I'm very aware of the differences in experiences between being an immigrant and a refugee. I engage in ongoing reflection on my privilege and biases, and I try to maintain a focus on anti-racist practice. And in regards to our newest community, the Afghan community, I have limited experience to date, but anticipate that I will become more familiar with that community, work more actively with those families in the future. As we mentioned, my current role is as the social work care coordinator at UVM Pediatrics, the Pediatric New American Program. And I also engage in ongoing consultation, training, and mentorship. So the Pediatric New American Program, or PNAP, is, as we mentioned, part of the UVM Children's Hospital Pediatric Primary Care. It's a specialty clinic which provides screening for new arrival children and health maintenance and prevention for new patients and patients who have been with us for many years. We focus on care that is patient and family centered, culturally and linguistically sensitive. And as part of that, we work very closely with interpreters and also cultural liaisons. We provide holistic care, really want to try to view patients and families in context and focus on their strengths and challenges. It's collaborative, coordinated, and community-based. So Dr. Green, Dr. Andrea Green, who is pictured here, runs the Building Strong Families Clinic, which is in the Old North End in Burlington. And this is based right in a community where many new Americans live. It's very convenient to get there. And she works closely with a number of family support workers from the communities that we serve. So my role at PNAP, I provide care coordination for our patients. We view social work as a critical component of the holistic care that we are providing for our patients. I collaborate with many community providers. I organize and participate in what we call care conferences, which are attempts to bring together a patient, especially older patients, family members, and the entire care team who is working with that patient. And so that includes medical providers, mental health providers, and other community providers, including school teams. I do a lot of work around identifying and addressing barriers to care, and we'll talk a little bit more about that as we go. And I provide mental health consultation, support, and referral as needed for our patients. I also spend a lot of time with family members, and I assist them with a broad range of challenges. These include expectable stressors, such as social determinants of health, and then more unique stressors. So when our families are involved in crisis situations, also to help mitigate some of the post-migration stressors that they face. And we will also talk more about those. And feel free to put any questions you have in the chat, and we will address those at the end. So just a quick mention of the benefits of embedded social work, which is something that I've been very fortunate to be involved in. So embedded social workers are vetted by trusted providers. So in the medical home setting, when a trusted provider introduces a social worker to the family, there is an implied sense of trust. We call that the warm handoff. And the social worker is acknowledged to be part of a care team. There is decreased stigma, especially when we are discussing mental health topics. So we're not in a traditional mental health setting. We're in a place where there's a focus on overall care. It might be more comfortable to talk about those topics in that setting. There's easier access to services. I'm able to build ongoing relationships with families, and many parents just walk in to meet with me or give me a call and ask if we can meet on a certain day to address an issue that they're facing. So that's something that, being embedded, I'm able to easily provide that. And then there's an emphasis on meeting the family's needs as a whole, rather than identifying a specific client who's in need. And greater capacity for coordinating and collaborating with other providers working with the family, as I mentioned when we talked about care at conferences. So who are we serving at PNAP? We use the term New Americans. That is a term that is kind of a catch-all. And it's also a term that not everyone who falls under that heading is fond of. So when we talk about New Americans, we are referring to recent arrivals, for instance, from Afghanistan. Arrivals within the past few years. We've had many arrivals from Democratic Republic of Congo in particular, but many other countries as well. Also arrivals within the past 5 up to 20, maybe 20 plus years. We serve children of previous arrivals, so kind of second generation, which is fun. We serve immigrants from many countries, and some of them might be undocumented. Asylum seekers who are here in our country and are hoping to gain asylum, which is a lengthy process. And then also in migrants, so refugees who were resettled in another state and have chosen to move to our area. to meet up with family or for other reasons. And just a note that immigrants and asylum seekers generally have access to fewer resources and are not eligible for many benefits. So I think it's always important to be thinking about context when we are looking at our patients and family members. So they are all part of a native culture and then a new culture. And I'll use the term the 1.5 generation several times in this presentation. And those are our patients who have kind of a foot in two different cultures, sometimes even more, several cultures, but they're really trying to bridge the gap between being from one culture and really trying to acculturate here in the US. And we'll talk a little bit more later about the challenges involved in doing that. They're also part of ethnic and religious communities, part of persecuted groups, and that can be the reason why they are here. But it might also be ongoing in this country that they face persecution. They're part of a family with a unique history of trauma and loss, a family with more universal stressors. The pandemic is a great example of that. And then they're also often part of multi-generational households. So to talk a little bit further about context, I think it's really important to understand for our refugee patients, what have they been through? If we kind of peel back the layers, what does that look like? So for many of our families who came here as refugees, they were impacted by pre-existing stressors. So before they left their native country, they had lives that might have been characterized by strife or stress. And these are some possibilities of what might have been going on for them, just like for anyone who was born in this country. And then the nature of the conflict that has led to their migration, there are different characteristics that can come into play in regards to looking at their future adjustment. And those can include the duration of the conflict. So what was their exposure? Was that brief? So for our Afghan families, things happened very quickly for them, of course, within the context of decades of conflict. And then for some of our other families, they might have been in refugee camps, again, for decades. Exposure to danger. How close did they come to risk? Were they faced with extreme danger at different points during their journey? And did they have the ability to prepare for flight? For some refugees in camps, it was something they were waiting for years and thinking ahead as much as they could. And then for others, it was a split-second decision. So to talk a little bit more about the next phase, which is flight or migration, it may involve prolonged exposure to safety risks, as I was just saying, and really prolonged physical, emotional, and psychological stress. May involve family separation, further losses, victimization can take quite a financial toll. I'm currently working with a family who basically sold everything they owned just to get to this country, and they have to start again. They may have been warehoused in refugee camps, as I was mentioning, and they might have traveled to a host country that let them stay for a little while and then kick them out. So coming to the US, that might not be the first country that they have fled to. There may have been a string of countries, and in each one, efforts to acculturate there. And I just saw this statistic in the newspaper the other day, and it just stuck with me. More than 29,000 people have died on migration journeys to Europe since 2014, with 5,000 perishing in the past 2 years. That is just migration to Europe. So that's not crossing the border, the Mexican border. There are so many other migration journeys that people are undertaking as we speak, but there's a huge toll that it takes on families. So we're going to spend a little more time talking about post-migration challenges faced by refugee families. And those include prioritizing your needs. When you have nothing, to use the example of the family who sold everything, where do you start again? And so basic needs issues become paramount. Access becomes paramount. Prioritizing the needs of parents versus children becomes significant. And then recognizing that there are limited culturally and linguistically sensitive service providers and resources, which is an area that we need to continue to work on. Adapting to new expectations in your new environment, dealing with the effects of trauma. And I'm really glad again that you're going to be hearing from Karen Fondacaro and Dr. Saida Abdi in the next presentation, because they'll go into more detail about this. Generational issues can also come up, and those can include the language gap, a knowledge gap, culture gap, and again, that 1.5 generation issue. So additional challenges for our new Afghan families include concerns about their legal status, the abrupt nature of their departure. So again, people were caught in a situation where they had to make really difficult choices. Families were separated. People came with very little. And it's very different than the experience of those who had a lengthy middle phase of this process. There are worries about family left behind, and that includes a sense of responsibility for those individuals, feeling like you are financially responsible for them, which means you have to work as soon as possible, make as much money as you can, decide how much do I send to my family as opposed to how much do I keep for myself. An overwhelming sometimes sense of guilt. And for further information, I encourage you to listen to the past webinar from June 30th of this year in this series, which was done by Dr. Andrea Green and Tracy Dolan, who's the state refugee coordinator. So in terms of adjustment to being in a new culture. I thought this quote was really powerful, and it's from a book called Suddenly You Are Nobody, Vermont Refugees Tell Their Stories. You live normal life. Suddenly you are nobody. Yesterday, everybody knows you, knows about you. Next day, you are no one. You are low, below low. So what does adjustment look like? So traditionally, people involved in looking at this have referred to the U curve of cultural adjustment, which is a very simple curve. But with further research, people have come to accept the W curve, or really what is here symbolized by a roller coaster. So it makes sense that there will be ups and downs to the adjustment journey. An important concept that I came across just recently in an article in the New York Times called Missing the Home You Needed to Leave is of cultural bereavement. And I think it's a really important concept to think about when you're working with new American patients or clients. So the definition is a specific grief reaction, which is caused by the losses involved in the migration experience. And this is not a new term. It was coined in 1991 by Dr. Maurice Eisenbruch. It's more complex and nuanced than the concept of culture shock. And it differs from PTSD, post-traumatic stress disorder, but it may coexist with that. And I thought that this quote from the article really explained this concept well. Feeling uprooted is something many immigrants are familiar with, split between the here and the there, between the push to assimilate and the pull to preserve parts of themselves and their culture. And it is often the intangibles from home, the smells and sounds, the metaphors and jokes in a native tongue that can't be translated, and cherished rituals that they long for. So the implications for social work intervention are to really be curious with your patients and clients, listen to their stories, empathize with the emotions, and validate those. And maybe most importantly, normalize those. I've said so many times to people who've shared their experiences with me, it makes total sense that you would be struggling with those emotions given what you have experienced. So the impact of post-migration stress on families. There are many possible ways this could manifest, and families may really struggle. So to start with, again, there are expectable social determinant of health issues, just like any of us could face. And those could revolve around housing, transportation, childcare, food security, financial security, all of those really important building blocks of family life. Also domestic violence, health and mental health issues, substance abuse, but also, significant disruptions to the way a family used to function, having to adjust to new roles, new practices, dealing with differing acculturation rates between individuals and generations, which can lead to conflicts between generations, trying to rebuild your support network, and then the impact of social media, which has been huge. On the plus side, it allows you to stay in touch with friends and relatives who may be scattered around the world, but it has a significant disruptive influence as well on the family. And from a more negative perspective, some outcomes of post-migration stress have been involvement with DCF due to differences in parenting practices, interface with the legal system, breakup of families, isolation. But also, I think it's so important to mention that many families experience growth and joy and demonstrate incredible resilience, which is really inspirational to me and my colleagues who work with this population. And for kids who have experienced post-migration stress, we can see the manifestation of this in many different ways, including emotional issues, behavioral issues, academic issues, and developmental issues, which may be challenging for parents to accept based on cultural beliefs. And so we have to really navigate how we talk about these issues and how we intervene. With teens and young adults, significant acculturation issues as they try to figure out who they are. So again, mentioning the 1.5 generation, maybe I am Nepali, but I'm also American, and how do I put those pieces together? For those patients who are trying to figure out who they are from a gender identity or sexual orientation perspective, those realizations, trying to be who you are, may be in stark contrast to your family's beliefs and practices, and can lead to isolation and sometimes even a child feeling like they have no place in their family anymore. So that otherness can lead to a lot of negative consequences, including dropping out, self-harm, negative choices. So this is an area of particular passion for me, really trying to help those kids who feel like they don't belong anywhere. The risks are so great for us really losing those kids to negative choices if we're not able to help them make connections and really feel supported. So a lot of the work that I do is addressing barriers. So we really want to make sure that patients and families are as connected as they can be to supportive resources, but barriers pop up to that. And these can include parent resistance to what we are suggesting. The impact of stigma can be huge and can be a barrier that's really difficult to get around. Many families don't understand the mental health system in the US. That might be new to them. And again, with stigma and fear about consequences, it could be hard to convince new American patients and families that this is in their best interest to participate in this system. And I'll just take this opportunity to say, part of the issue is the system needs to adjust to meet the needs of individuals from non-Western cultures and really change practices and use interpreters and cultural brokers so they could best meet the needs of this population. There may be differing interpretations of the issue, and the intervention suggested based on cultural or religious beliefs may be hard to get your kids to appointments. Transportation's an issue. You work second shift, you're a single parent. That's something that parents may need help navigating. And the impact of cultural beliefs about parenting and discipline comes up again and again. And again, that's something that we really need to figure out a way to discuss in a more objective way, a less judgmental way, to really engage parents in figuring out how to best support their children. So I'm going to just share some lessons that I've learned over time. And the first one is kind of an obvious one, but it comes into play again and again. Meeting the client or the patient or the family member where they're at. Recognizing that where they're at might be, I can't pay my rent this month, as opposed to, I experienced so much trauma and I want to talk about that. I think sometimes when people are working with refugees in particular, they jump right to that. But you need to build trust by listening to the client's priorities and working with them on those. Sometimes providing support and bearing witness. So just listening is enough in that moment. That's what actually is needed. I talked about removing barriers to wellness and success, and that includes providing education about resources, helping people connect with them, but also challenging systems barriers and advocating for increased culturally and linguistically sensitive care. I spent a lot of time doing that. It's really important to me. It's really important to our families. So in my experience, removing barriers to successful adjustment is probably the most useful intervention that we can provide. A few more lessons. We don't need to be experts in each specific culture, but it's really important that we do educate ourselves about historical context, traditions, values, when we have a family from a culture we're unfamiliar with, so that we can best understand their context. We can assume some level of trauma has been experienced by refugees in particular, but we need to be cautious about, I didn't finish my thought there, about assumptions that we make about their experience or how significant it is to them in that moment. In general, avoid stereotyping and assumptions and view clients as unique individuals. Recognize that family and community context may be more relevant to our patients and families than it might be for individuals who have grown up in the US. And recognize diversity within diversity. By that, I mean not all groups are the same. Not all members of groups are the same. Really look at people as individuals as much as you can. And then also get guidance from the larger context. Some further considerations. Offer refugee-friendly resources for needs you can't meet. So it's really important to know what kind of greeting someone's going to get if they contact a certain organization or service. And we may need to advocate and educate those service providers who are not refugee-friendly or who are working on that skill. Recognize that families are often connected to other providers, so try to avoid duplication of services. In my experience, a lot of families will come in and they will talk about stressors. That doesn't necessarily mean that they need assistance with that today. They might already be working with someone on that, but they are just expressing frustration, the reality of their current life. It can be really helpful to ask, is anyone else helping you at this? Or even to do an eco map with them and really map out everyone who's involved with them. We can all model strengths and resilience-based approaches. And remember that any actions we take towards strengthening a family also strengthen our patient in the long run. And be patient, flexible, and creative when needed. And I'm going to end with this slide, which is just a reminder of Maslow's hierarchy of needs. And for any of us who could face a crisis situation, could be in a situation where we have to start over. You start with attending to basic needs, building self-sufficiency, and then rebuilding some really important pieces of our lives, which include feeling safe, having a support network, having a community that we belong to, having future orientation, and having hope. And that is something that too often is taken away from our families, and we can help them get at least some of that back. So thank you so much for listening today. And I'm not sure there are any questions, but if there are, I'm happy to answer them.
Great. Thank you, Cathy. We do not have any questions right now, but if I will be sharing our recording, and if anybody has any questions after watching it on our YouTube page, I will direct them to you as well. But thank you so much for the presentation today. And thank you to those that joined us, and thank you to anybody that watches it on in the future on our page too. So with that, I will conclude our session today, and I'll be sending out the CME information to those that joined by the end of the week. So thank you again, and hope to talk to you all soon. Bye-bye.
Great. Thanks so much.